Hi guys, welcome back to our channel. Today we're going to be going over pericarditis and myocarditis. So I'm going to go ahead and start off with pericarditis, the acute version. So with pericarditis, that is inflammation of the pericardium. The pericardium is the sac that's over the heart. And so as far as causes, the number one is going to be idiopathic. 90% of acute pericarditis is idiopathic, meaning that there's no known cause. Another cause could also be due to viral infection. So we're going to move down to the presentation. The big thing is going to be chest pain. So a lot of times when a patient comes in for chest pain, you're automatically going to assume this could be like a STEMI or a non-STEMI, some type of ischemia or an MI. And so a way to differentiate this is with movement. So when it comes to acute pericarditis, you're going to find that your patient's going to tell you that it gets worse when they're lying down flat, when they're swallowing, when they're coughing, or when they're doing body motion, and you're not going to find that with an MI. Another thing is that it gets better when they sit up and lean forward, which kind of makes sense because it's the opposite of that lying flat. Another thing is that they're going to describe it as a pleuritic pain, so with inspiration and expiration, they have that difference in pain. And then also the friction rub is a very big thing to note. So when you're listening, you're going to hear a friction rub. Sometimes it's described as like Velcro being torn apart. And so I put these flags next to worse when lying flat, as well as friction rub, because those are the two things that should stand out to you, especially on a question when you're going through exams. So we're going to move down to something that's called a STEMI impostor, and that means that it can sometimes be mistaken for a STEMI. The way to distinguish this is that it's diffuse throughout the whole EKG. So meaning that in every lead you're going to see this ST elevation, which is not typical for a STEMI, and also it has a saddleback characteristic. Now next down to treatment, we're going to go over that. So it's going to be an NSAID and a colchicine, and so specifically you want to use endomethacin when it comes to the NSAID option. So now we're going to go ahead and move over to myocarditis. We're going to have Shannon take that over.
Okay, so we're talking about myocarditis. A big thing kind of with pericarditis versus myocarditis is that we're building a differential with these conditions. So a patient comes in with chest pain, kind of vague symptoms. You're going to be thinking myocarditis, endocarditis, pericarditis, STEMI, all of these conditions before we really dig in. So make sure you're kind of thinking big picture with that. One of the big differences with myocarditis versus pericarditis, with pericarditis it's idiopathic. We don't know the cause, it's just that the pericardial sac is very inflamed and you're getting that pleural friction rub and everything like that. Whereas with myocarditis, it's also known as inflammatory cardiomyopathy because something else is causing the problem. So we have underlying pathology such as a virus or bacteria or an autoimmune process that is manifesting itself as an inflammation of the myocardium. So really just keep that in mind. Pericarditis, it's idiopathic. The problem is with the pericardial sac, whereas myocarditis, the problem is with the underlying condition. So that kind of makes sense. You'll see when we get into treatment, the treatment is just we're going to find out what the condition is and treat it. So red flag with myocarditis is that you have a recent flu or upper respiratory infection. So with myocarditis, if you see pants, it says we have a viral prodrome phase. So the beginning is some kind of virus, and then you go into the heart failure and other symptoms. Another red flag with myocarditis, this is very board heavy, is Chagas disease. So Chagas disease is due to, I think this is a protozoa, Trypanosoma cruzi. This isn't found so much in the US as in Latin America, so definitely keep that in mind with patients who have emigrated or with patients who have recently traveled throughout Latin America. Chagas disease, myocarditis, you just got to put those two together in your head. And then the etiology I mentioned already a couple times, but to reiterate, viral, the most common virus is adenovirus, bacterial, and then protozoa, the Chagas disease, and then also autoimmune. There's a couple other etiologies as well. It's very multifactorial. Diagnosis of myocarditis. Everything, because we just want to find out what is causing this inflammation of the myocardium, what is causing this patient's chest pain, all that. So EKG, echo, cardiac MRI, BNP, troponin. One thing to note with the troponin, this is one of the gray area troponins. It is going to be falsely elevated. So you're going to get this back and you're wondering about an MI, but hopefully the whole clinical picture will help you come to this point that it's not an MI. And then biopsy. For the purposes of our class, the biopsy parameters were very specific, and they don't totally make sense, but I'll just go over them real quick. If it's less than 2 weeks, Since symptom onset and the patient has heart failure and hemodynamic compromise, you're going to go in and biopsy. I think a lot of that is with the hemodynamic compromise. It's like we can't even keep the patient alive, their blood pressure is falling. We have to go in and find out really what is causing this if we can't find out another way. And then if it's been greater than 2 weeks and your patient is still having symptoms and we're not sure exactly why, biopsy. So, or greater than 2 weeks with dilated left ventricle, we're gonna have to go in and find out what's going on with the biopsy. Treatment, treat underlying conditions. So beta blocker, once again, if it's been like the 2 weeks and you have left ventricular dilation or low ejection fraction, you gotta put them on ACE. NSAIDs, particularly, you can have pericardial involvement. So if it's myopericarditis, you gotta do the NSAIDs and colchicine. And antibiotics if we find out that it's bacterial myocarditis. And then if the patient is really not doing well and needs a heart transplant, then an intra-aortic balloon pump or an LVAD as bridge to transplants. So today we went over myocarditis and pericarditis. Remember, pericarditis, idiopathic, myocarditis. This one I don't really like, it's kind of confusing, but just kind of try to remember the viral prodrome and the Chagas disease, and those are kind of like the big things. Thank you.